Thank you so much for having me. It's an honor to be here. So the genesis of Troy Medical was the beginning of COVID, and honestly, one of the silver linings that in medicine became telehealth. Telehealth had existed, had struggled, had been vaguely accepted, mostly not accepted until COVID hit. And all of a sudden we were forced, and we discovered that lo and behold, actually people could get really quite impressive medical care via telehealth. Harnessing technology into medicine. So the genesis of Troy Medical was the concept of having a fractional doctor being brought into a community that didn't have any access to these specialists via a telehealth model. But the important part is that what telehealth does miss is, one, a human connection there on the ground, and two, someone to help you navigate this entire process of medicine that is so much more than the doctor saying, oh, that's rheumatoid arthritis, go take this pill. Because medicine is the entire structure, navigating all of the infrastructure. The how do I get there? Who do I call? What do I do? How do I get my insurance to do this? Where do I go for my medications? Like, you know, you're the social worker. I mean, I see you nodding. You're like, yep. Medicine is so much more than just the doctor telling them what their disease is and what pill to take. So how do we bring that entire infrastructure and the specialists into remote and underserved America? So the idea for Troy Medical was born. My staff begged and pleaded for me to please not have a giant new project in the middle of 2020 COVID winter, right up until Troy walked in. And Troy could barely make it across my clinic office. I had taken care of him for a decade, and I'd watched his disease eat his body apart. I'm just his eye doctor, but he needed a rheumatologist, a neurologist, an endocrinologist, and I could provide him none of those. So the concept of this idea that I had, when it became the person that I could or couldn't help, I walked out of his exam room in tears, and I looked at my staff and they looked at me and they said, we're starting the company. I'm like, yeah, we're starting the company. So the company was named after him. And so Troy Medical was born. So for the past, like a year later, after all the formation documents and all the stuff that goes into building a new business, we launched about last March. And I launched with a rheumatologist, a neurologist, and an endocrinologist. And what we were doing is we were proving that this model would actually work. How can we bring subspecialty medical care into remote and underserved America and provide top level medicine? Not a one-time consult, not a help your primary care doctor figure out what medication, but a doctor, a specialist who owns this disease, their exact medical vertical. They own this concept and they own your disease. They're long-term committed to your chronic disease. Best practice medicine is as high a level specialty as you can possibly get, providing long-term chronic care for a patient with a chronic medical condition. That is the target. That's the goal. Not a consult. It's not someone helping a primary care. It's saying, you have lupus. I'm going to figure out how to treat your specific lupus, navigate your exacerbations, your side effects, understand your impact of the disease, the treatment, all the other things that go along with it, because I am a rheumatologist. I understand exactly what this disease process is doing. And they do it on a long-term basis. I'm your doctor, just like I would be anywhere else. You happen to live in Fairbanks, Alaska. I happen to live in Florida. So can I give you my medical expertise with hands on the ground and all of the medical infrastructure to be able to provide, you know, an MRI, an X-ray, laboratory, like so much of medicine can be practiced without actually palpating a physical joint, that we actually can go harness medical technology to have a doctor living in Florida treat a patient living, or a doctor living in Florida treating a patient living in Fairbanks, Alaska, and provide exceptional medical care. Where unfortunately the other nearest rheumatologist is 400 miles away with an 8-month wait list or a 4-hour flight to Seattle. So those are what the options are. We started this beta test in Fairbanks and it has been wildly successful. We are doing fantastically, so much so that we just expanded into hepatology, gastroenterology, and dermatology, and are continuing to expand our scope. We're actually also now looking to expand this outside of Alaska. I started in Alaska because I knew Alaska. Fairbanks they're my people. I've been treating them for 15 years. Like, I know every single one of them. So I started this company for my patients. But, you know, my Troy is everyone else's in all of their towns and all across America. 20% of America lives in rural America, and 80% of rural America is medically underserved. So this exact problem exists across the country. So I created a model that is now templatable. And now that it's working so famously in Alaska, we're starting to take it elsewhere. So that's Troy. And Troy's going to keep growing. And Troy's going to keep serving everybody else's Troys. So that's Troy Medical in a nutshell.
Well, fantastic. Thank you, Kara. What I love about having this presentation here today is I think even though we're a small group, we have such a rich number of experiences here. One question I have is, you said you're going to take this elsewhere, but in Alaska, have you thought about launching like a physical location in other communities as well?
I have. So Alaska is, we are working for, right now we're working through some logistical issues that Alaska has. And one of the biggest ones is being able to get licensure. It's taking people about 6 months by the time I hire them to the time I can get them into clinic. And everyone here is nodding with these big acknowledgements of this is a problem. I've spoken to the state legislature, I've spoken to Alaska State Medical Association, I've spoken to lobbyist groups. Right now, it is really, really hard to get a doctor licensed in Alaska. The application is ridiculous. I am currently, in the past 3 years, have gotten licensed in Texas and Washington. I'm now getting licensed in Idaho. So I can, because I have to be licensed in every state I expand into. And let me tell you how easy those are. You fill an application on a uniform application, it says same, submit. You go to the FCDS and you say submit. And then you get fingerprints and then you're done. Or in Idaho, you even so expedited because they're part of the compact. In Alaska, it is all analog. There's no feedback. There's 2 people who you can barely even get a hold of, and the doctor has to do all of the work, and it takes absolutely forever. So this is a problem. So in order to be able to expand in real time, I need to be able to, get doctors in right now. I just hired a gastroenterologist. I'm expecting their launch date to be in 6 months. That's painful. Like this is a real problem, and I'm working to fix it, but unfortunately it's not in my control. So until the powers that be can figure out a way to navigate the medical licensure, getting doctors into Alaska is difficult. Because by the way, this isn't a full-time doctor. They're coming in for 8 hours a week because Fairbanks can't afford a full-time hepatologist. There's not enough liver disease. So I have a hepatologist who's going to be working 4 to 6 hours a week, a gastroenterologist working 8 hours a week, a dermatologist working, although we could probably do a full-time dermatologist. But the idea is that we're doing a fractional doctor. And so if you put in 50 hours of work to get a medical licensure for 8 hours of work a week, like, come on, this is a problem. So Alaska needs to figure out a way to help fix Alaska's access problem. So if anyone knows anybody who can help navigate that, I would love to start a clinic in Juneau and Sitka and Barrow and Nome. I'm chomping at the bit for it. Alaska's my town. That's my home. And so in the meantime, Texas has these problems. Eastern Washington and Idaho have these problems. Nebraska has these problems. Believe it or not, California and Florida, Hawaii, Vermont, Colorado, name it. We did a needs analysis, and I actually had to shut it down because the need was overwhelming. And the access question was, we took neurology and rheumatology, and we said, if you needed one, are they within a 2-hour drive and have less than an 8-hour or 8-month wait list? And the number of patients, I can see people's heads shaking and nodding, like the number of people, the number of communities who failed that metric was enormous.
Thank you, Kara. Elizabeth, I think you unmuted. Do you have a question that you would like to say?
I actually had a comment and a question. Thanks, Jacqueline. Kara, I'm Elizabeth King. I'm the Senior Director for Behavioral Health and Workforce with the Alaska Hospital and Healthcare Association.
Oh, great.
And when you said you were bringing in part-time doctors from out of state, I was like, how is she getting them licensed? Because it is a problem across the board for all of our facilities. It's really a struggle, and we are trying to work on it, but it's really challenging. There's a number of issues involved. But my question is, so how does it work on the ground? So how do patients interface with your clinic?
So they actually come into clinic just like they would at just like a normal clinic. So we have a tiny little micro clinic on the ground with an MA. So the MA brings them in, they fill their paperwork out. If they can't navigate the tech, which is such a problem with telehealth, especially in rural places, especially with elderly. So they can't navigate the tech. So we have somebody there literally physically on the ground helping them navigate the technology, getting them signed in, we put them into a little exam room, which honestly doesn't need to be more than just a teeny tiny little space with a computer and a monitor, and gets them signed in, and then the doctor comes in on the screen. And then the doctor, if there's a question they need vital signs, or they get vital signs and weight and all their basics. They do the review of systems, they get all the basics like a normal MA would. And then if the doctor needs something more, they have hands on the ground to be able to do it. If they need the MRI form filled out with the questionnaire of, those 30 questions to get an MRI, or the lab form, or where do I go for my labs? Okay, you go here, but it's a genetics, so you can't go on a Thursday or on Friday, it has to be on a Thursday. This needs to be fasting, that doesn't. So that person is there answering all of those questions, doing all their follow-up. They get all the orders done in the EMR just like they would normally. And so the only rate limiting step for medicine is the specialist. Like, you just don't have the specialists. So we provide them on a fractional basis. And then the MA, whoever's on the ground, actually can navigate all of the rest of the orders just like a normal MA would. They're the ones who make sure their insurance authorizations are done. They do take their co-pays. We also have a back office who does all of the navigation of their benefits and their postings and all of the infrastructure that goes into medicine. But you need to have a person on the ground to help hold their hand and walk them through the confusing part of having a chronic disease, which is, I need an insurance verification. What? Where do I go for this? Or the classic one where the doctor spends all this time explaining in perfect detail everything, and the patient walks out and says, I don't understand what she just said. Where do I go now? So you need to have that person, because I only want to say the number of times I thought I explained in exhaustive detail and the person has no idea what I just told them. And so you need to have someone who can translate that, who isn't the big scary doctor, because nobody wants to ask the doctor, I had no idea what you just said, but they'll ask the MA. So that person is a crucial part of the medical system. And medicine is more than just the doctor writing the prescription. You also need a person who, the pharmacy doesn't have the prescription, can you send it again? Or I lost this, can I get a refill? All of those things. So it works just like a normal clinic. The patient comes in and does that. Dermatology is going to be a little bit different, because dermatology is just a phone call. They wanted to have a picture and a phone call. So they're going to take a picture and call the person, and an MA is going to call them and start the intake. So that one's going to be a little bit of a different structure. If and when we're able to get psychiatry, it's probably going to be, again, a little bit different, because so much of that is different than like an endocrinologist or a rheumatologist or gastroenterologist, who needs a little bit more support than a psychiatrist would.
Awesome.
And by the way, our new model, as we're going to new clinics, is actually partnering with hospitals on the ground, because, by the way, rural hospitals are kind of getting crushed, as I'm sure you know. Yep. So the economics of rural hospitals are just awful. In the past 10 years, over 120 rural hospitals have closed down, and 40% are operating at negative margins, 20% are near collapse. I mean, across the country, this is a huge issue. If you keep all of this stuff local, what that means is that the MRIs, the infusions, the labs, the minor procedures all stay local in that community hospital. And from an economic standpoint, if you're able to keep those local in that hospital, their economies actually benefit as well. So, utilizing those ancillary support services, that is actually where a hospital makes its margins. Lord knows it's not from the ER. Or inpatient. It's really from outpatient surgery, infusion centers, radiology, dialysis units, laboratories. And so if we can keep those patients in their communities, it actually is going to benefit the survivability of the community hospitals. And
it's so much better for the patients.
So much better for the patient. I mean, not even just a little bit, it's so much better for the patients. I mean, 1,000-fold, not even the fact that if they actually can get access locally, they're likely to get access.
Yes.
If they have a problem, they're actually likely to navigate and manage it. And if you're able to treat disease states at an earlier date, the outcomes are just absolutely massive. Plus, the impact on the healthcare system is financially advantageous. So it's, I mean, every single bit wins. The patient wins number one. The system wins number two. The economics win number three. Like, I mean, every single person wins on this, which blows my mind that nobody else is doing this model. So, all right, let's do it.
Go ahead, Elizabeth.
So, you know, Jacqueline had asked if you would consider expanding within Alaska, and it sounded to me like you would if the licensure piece got figured out.
So there's a couple things with this. One is, you know, the beta testing, the overhead to start a clinic from scratch, it's not for the faint of heart. So you know, this is all self-funded. It's my passion project. So what we're doing as we're scaling is we're trying to work with with hospital patient doctor groups, so of which there's lots of them, and going in there as almost like a 1099 contracted entity that you can. So we will bring and manage all of these providers. So you don't have to do any of that work and any of the stuff that goes into it. We need to contract with you to have a micro clinic on the ground and a little MA and a little bit of the infrastructure that already exists within the clinic to be able to utilize that space. So we're not having to go in, reinvent every single wheel at every single location. We can do all of the stuff. We need a partner on the ground to, you know, where do you send the labs? Where do you send this? Where do you send, you know, who do I send for scopes? Where do I send for liver biopsy? Where's the dialysis going to be done? So I need people on the ground who have all of those answers. In Fairbanks, I knew it all, but in Juneau, I don't. So I need somebody there who. So that's why we're looking to partner with, you know, hospital physicians, because by the way, the hospitals are winning in this. The physician groups can offload. I mean, no primary care doctor wants to be managing lupus. Let me tell you that one. And so we can take all of those higher level, very onerous, very time consuming cases off of them onto the specialists where they belong and provide this on a long-term basis. And so the synergies of working with a hospital physician group are obvious. So if you know any hospital physician groups in Alaska who would be interested in bringing subspecialists into their medical system, feel free to reach out, because I'm willing to do it. For sure, I'm willing to do it if I have a partner in the community who can help me navigate all of the infrastructure of the community itself.
Awesome. So this is a good point. I put it in the chat, but if anybody wants to add their contact information into the chat, Kara, if you would do that as well, then we'll make
Absolutely
cross connections. I'm going to open this up. Elizabeth, you are so knowledgeable. You are more than welcome to continue, but are there other people that might have a question? Thank you, Kara.
Absolutely.
So one of the things that we always like to talk about is what can we do for you? So it sounds like connecting you to hospital groups. I'm thinking of like the Healthy Connect that, you know, our local healthcare information exchange would be a great partner for you. So that's one idea that I can follow up with afterwards. What else can we do for you, Kara?
So one obvious answer to me was to partner with the Native Corporation, because can you imagine the impact of being able to provide fractional basis to every village out there? They already have the infrastructure of a health aid on the ground in the villages. For them, they have to fly all the way in, or sometimes all the way down to Seattle, which is terrifying when you've lived in a small town. And you know, the impact of being able to provide this into rural Alaska, not even small town, you know, not even Fairbanks, which is, you know, second largest city, but into some of the villages and some of the smaller towns, I would love to partner with them. You know, if the being able to scale this to that level, like with the infrastructure that already exists within the Native Corporation, you know, ANMC has enormous potential in this. I don't know I know they have a lot of specialists, but I'm sure they don't have enough. And being able to implement this into you know, their processes, I think would be an absolutely enormous. It would level up what you could bring into the villages.
Wonderful, thank you. Please go ahead, Elizabeth. If you have any other ideas that you could share with us, I'd welcome them. I'd love to hear what you have to say.
I think, you know, there's obviously so much potential. And there's so much need that's not met. I feel like it's kind of a no-brainer. And I think that the challenging part is making those connections, and figuring out all the like the little logistic pieces, like who, what, when, where, all those pieces. And I actually feel like it'd be great to connect with you offline so that I
I'd
could.
absolutely love to.
All right.
Yeah, absolutely. My email, I put my email into the chat. I mean, like I said before, this admittedly it's my brainchild, and so I obviously believe in it to the bottom of my heart. But like, you see the impact of what this has done just in Fairbanks. I mean, the patient quotes that I get just blow my mind. My soul just like, oh my gosh, this is what it's all about. When people come out and they're like, finally, you're like, yes, this is why I did this. And we should be able to do this everywhere. We've thought of the idea. Now it's just a matter of how do you get over the hurdles of the bureaucracy to get that in there? And those are finding one champion who's willing to open the doors. And so that's all we really need, is somebody to open the door. I now have validated the model, and we've gotten to the point where we're at the point now where we've scaled enough that we're going to be profitable. So this is and the idea of creating something that has legs, that actually it's not a nonprofit. You're not constantly trying to beg for money. It is a self-sustaining organization because it self-funds. We accept Medicare, we accept Medicaid, TRICARE, VA, you name it. We accept every single thing out there, with the idea being we want to be able to keep this open to every single person that lives in an underserved area.
Awesome. Thank you, Kara. Alan, can you please ask a question?
Absolutely. Hello, doctor. It's a pleasure to meet you. Thank you for your presentation today. I had a question for you on the licensing challenge that you're facing. Are you currently working with the legislature or a legislator in particular to bring forward that conversation?
So I was for a while. We just went through a cycle, so everything kind of stopped for a little bit. As I'm sure you know.
You're not busy.
So about a year, I think it was probably about a year ago, we actually made a big push. And I even spoke to lobbyist Kevin, who, he does lobbying for the Alaska State Medical Association. One of the issues is that the doctor groups actually aren't super highly motivated to make it easier to get credentialed or to get licensed.
Kind of thinking that might come.
Yeah, and so I met with them, and I actually got a shocking amount of pushback, which kind of blew my mind. And so that was not going to be the route to be able to get this change done, which really surprised me. I've spoken to a few specific legislators, so I don't know if I should name them, if it was confidential or not, who were all ready to do this, and they ran into me. They even had funding for it. So one of the issues was whether or not you could find somebody to go redo the system, because it's a big project. It's a lot of bureaucracy, and finding somebody who right now is I think it's 30% staffed. I mean, their staffing issues are enormous. So finding someone who will put in all of the effort and energy to revamp the entire system, or take another state system and implement it into Alaska. So that's one of the things you're looking for, is just taking Washington system and putting it into Alaska. The physicians didn't want to join the compact. So getting that through, which makes no sense to me at all. But again, so it was the hurdles were from within as much as they were from without.
Thank you. That's hard to hear, but not unexpected. So
yeah, it was surprising to me. Like, it was really frustrating to me to realize that my fellow physicians were unwilling to they're unwilling to make it easy to bring in life-saving providers to go help my patients. So I did not take that well.
Oh no, Elizabeth.
That's not great. But I mean, and that's one kind of issue, is that the path isn't easy. But another issue, and the reason why they're only 30% staffed, is because everything is analog. And you said that yourself, like other states, everything is digital. You do digital fingerprinting, you do digital background checks. In Alaska, everything is paper and fax, and it takes so much longer.
It's insane. It's absolutely insane. Even if they changed nothing but and someone said that it's funded. They just need someone who will go in there and put in all the effort to change it out. So I'm hoping that this legislature season, somebody will be able to go do this. I have a couple contacts that I've been kind of waiting for things to settle out, to call up again and say, hey guys, like just task this on the priority list and get it done. And, you know, Elizabeth, you probably know more people that have more push within the hospital systems. I know I've spoken with, you know, Fairbanks Memorial, and they're having the same issues. Of course they are.
Oh, yeah.
Providences, I know, I mean, Alaska Regional, everybody's having the same problems. So
yeah, our main legislative push this season is the Nurse Licensure Compact. And one of the thoughts about the outcome of that, if we are able to do it, would free up additional time for state workers to do physician licensure. So maybe a win-win.
yeah, hopefully. So
Well, thank you both. It is always disappointing to me to hear that it's bureaucracy that's slowing when we have champions like Kara, you know, Elizabeth, everybody here is a doer. And so when you get stopped by regulations or by bureaucracy, it's always a little frustrating, especially when you're trying to make real impact on the ground. I do want to point out that you have amazingly made this first clinic happen, and that you're impacting huge lives. Anybody who's ever had to fly down to Seattle, we're running out of time, and it's not fair, but I'm going to call out Kim Champney. You know, she is the director of the Alaska Association of Developmental Disabilities, and when I think about the model that Dr. Hartl has, I really think about how much easier that would be for your populations, Kim.
I would agree. You know, often families work around specialty clinics when, like you were saying, that they get to see a doctor for 15 minutes and a quick consult and it's done. So it's not my system. I feel like Elizabeth has a lot more understanding of how you change the primary care system than I do, but it certainly would be a benefit for people with disabilities who have specialized medical needs, for sure.
So
yeah, the idea is you know, drive, fly, whether to Anchorage or Seattle, and you have your 20 minutes with the doctor and then you're done. Like, really? That's an 8-hour flight?
Right.
And $2,000?
yes, absolutely. Well, we're all champions of what you are doing. Thank you so much for presenting here today. Thank you all for coming. We will have another Health Tie Open Innovation in 2 weeks on the 16th. We actually have a group called Coco Health that is trying to improve communication. It always seems to be about communication, trying to improve communication for people, for caregivers. And so thank you all. I hope you'll join us then. Thank you, Kara, again. If you can, please, everyone, either virtually or in person, provide an applause. And Kara, please reach out anytime. We're going to stay in touch with you and try to help you and move your ideas forward. So thank you very much for coming today.
Fantastic. Thanks so much for having me. This was wonderful. Elizabeth, I look forward to speaking with you offline. Thank you so much, everybody.